Welcome, everyone. We will be getting started shortly. We just want to let everybody in first. Okay. Thank you for joining us this afternoon for this webinar brought to you by the Northwestern University Feinberg School of Medicine Medical Alumni Association and Women in Medicine Subcommittee. I'm Angela Moda from the Feinberg Development Office, and we'll be moderating the presentation. Our topic today is Women's Health and Aging, featuring Dr. Kara Goldman, Associate Professor of Obstetrics and Gynecology, specializing in reproductive endocrinology and infertility. She's also the Medical Director of Fertility Preservation and Associate Program Director for the Fellowship in Reproductive Endocrinology and Infertility. Following her presentation, we will have time for a Q&A. We'll try to get to as many questions as we can during that period. I have some questions that we received in advance, but you may also submit your questions using the Q&A feature during her presentation. Thank you and welcome, Dr. Goldman.
Thank you very much. And as I get my screen shared here, perfect. Thank you very much for the kind introduction and for the opportunity to speak today. It really is an honor to be here. And you may have noticed on the invitation, Dr. Francesca Duncan was planning to join. She unfortunately was unable to, but I will be speaking on both of our behalves today. We work very closely in collaboration. I have no commercial relationships to disclose. And I'm going to start here with Juan Ponce de Leon. He might be a figure that looks familiar to some. He, of course, was the Spanish explorer who in the 1500s set out to find the fountain of youth. And unfortunately, instead of the fountain of youth, he found Florida. But we know that this has been a perpetual search over many centuries for this kind of elusive fountain of youth. And we're going to talk a little bit about that again later. What is truly incredible is that over the course of the last century, we've seen a significant rise in global life expectancy. So if we look first at the year 1900, the average life expectancy in the Americas in green was in the low 40s. And of course, this number was brought down by very high infant mortality. And so average life expectancy was much lower. But we see that there has been, over the course of the last century, about a 30-year increase in average life expectancy. And there are a few ways to think about lifespan. There's, of course, just the length of time that someone is alive. But really, when we think about reframing the discussion of aging, we really need to be thinking beyond just lifespan and longevity to health span. What are the years of healthy life that we have? And within that, there is also this very important yet understudied and underdiscussed reproductive span. So the time in our lives when we are not just healthy, but have reproductive health as well. And so we know that Time magazine and a lot of the kind of popular media tends to be a mirror for popular thought. So let's think about these Time magazine covers and how this is a reflection of popular thought in terms of aging. So 1996, we see this cover, how science is searching for ways to keep us forever young. A decade later, in 2004, how to live to be 100 and not regret it. And then all of a sudden, 10 years later, a decade later, now we're living to be 142 years old, Dispatches from the Frontiers of Longevity. And most recently, I saw this cover when I was at a local bookstore. And of course, I was drawn to this, Time magazine, The Science of Living Longer. And this was a 22-page health section. And I looked with interest, thinking, well, great, there are women on the cover. This is definitely going to talk about reproductive aging. There's 22 pages dedicated to this. And in all 22 pages, there was no mention of women's reproductive aging and aging in particular in women, just a general kind of discussion about aging. And so I think that's really an important piece that we're going to have to get back to over the course of this talk. So longevity is, as we all see it around us all the time, it's this trillion-dollar industry. There are a lot of people trying to sell you supplements. There's a lot of discussion surrounding longevity. And this is a representation of the global longevity ecosystem from 2021. All of these small little dots represent companies, investors, and governmental agencies that are dedicated to longevity. And in fact, there are now 23,000 companies that are dedicated towards to trying to identify ways to lengthen lifespan. And it also has become now this important academic and scientific priority. So the Buck Institute is an institute that was started in 2018, funded by Nicole Shanahan and Sergey Brin, who's the co-founder of Google, and his wife, Nicole Shanahan. And they funded this Center for Reproductive Longevity and Equality, the goal being, let's try to identify ways to improve reproductive longevity. The NIH has made longevity, and in particular reproductive longevity, a very recent priority. So as of just the last couple of years, the US National Academy of Medicine has dedicated this global roadmap for healthy longevity. And so we see that there's this really strong push towards longevity and making this a priority within academic institutions. And Northwestern just launched our very own Longevity Institute, and this was launched just January of this year. This was Dr. Duncan, Francesca, and I at the kind of a brainstorming session for the Institute, and we are in a sea of non-reproductive scientists talking about reproductive longevity and trying to really make a push for let's have the ovaries, let's have reproduction be a part of this conversation, and make sure that our voices within reproduction and women's health get heard. So let's talk in general terms about aging. This is a really kind of landmark figure from a Cell paper in 2013 going through the hallmarks of aging. And if we start at 7 o'clock here at mitochondrial dysfunction, we'll work our way around down to deregulated nutrient sensing, but these are the hallmarks of aging. So mitochondrial dysfunction, cell senescence, stem cell exhaustion, altered intracellular communication, genomic instability, telomere attrition, epigenetic alterations, loss of proteostasis, and deregulated nutrient sensing. And this is where I'm going to spend a lot of my time here because this is where a lot of my research focuses. So what are nutrient sensing pathways and longevity? If you've heard of David Sinclair, if you've heard of the book Lifespan, then you've heard of these nutrient sensing pathways. So this was a gotcha title here. Has Harvard's David Sinclair found the fountain of youth? And certainly no one is claimed to have found the fountain of youth, but there are a lot of really compelling mechanisms and pathways here to think about ways to prolong lifespan and health span. And so when we think about these pathways, we're thinking about caloric restriction, we're thinking about sirtuins, and we're thinking about tuberous sclerosis complex and mTOR. These are all key regulators of growth, metabolism, autophagy, and aging. So to dive a little bit further into these pathways, and then we're going to take it back a little bit and talk about the ovary and talk about women's health. So these pathways are all really critically important in controlling the response to biological adversity, including DNA damage, hypoxia, reduced environmental resources. And there are numerous studies showing that these pathways, manipulating these pathways, can lead to prolongation of lifespan and health span. So starting with caloric restriction, this is a study done in the gray mouse lemur published in Nature Communications. And if you look at the red line, that is, those are animals that were calorically restricted, and the blue line are controls. And so focus your attention on B, so figure B here. These are animals that were calorically restricted and had a significantly longer survival compared to controls. And this is really seen across many, many species. So this was notable in that it was in a primate species, but we see this in many species. Sirtuins, also very important in that pathway, also somewhat regulated by mTOR, extend lifespan and delay aging in mice. So again, here we see female mice on the left and male mice on the right. And the female mice are living longer when we are manipulating sirtuins. And the prolongation of lifespan is more significant in the females than in the males. And rapamycin, so this is just now one example of some of the work being done with mTOR, and I will dive into what exactly is mTOR, but rapamycin is an mTOR1 inhibitor. It was the original inhibitor of mTOR. And what we see across many, many species is that this mTOR inhibitor leads to prolongation of lifespan really across so many species. This study here is in mice, published in Nature, but we see that the prolongation of lifespan is more significant in rapamycin-treated females than in males. And what's interesting is, when we think about, well, gosh, no one really wants to calorically restrict. That's a very unpopular way to think about prolonging lifespan or health span. The impact that we see with caloric restriction in terms of prolongation of life is very similar to what we see when we give rapamycin. So rapamycin, the mTOR inhibitor, is essentially a pharmacologic way to get the same phenotype that we see with caloric restriction. And importantly, now we're looking here at data published in 2019, looking at rapamycin and caloric restriction in mice, and then looking at the ovarian phenotype. And we see that there is preservation of primordial follicles in both rapamycin and calorically restricted mice. So the phenotype, really what I'm saying here is that the phenotype that we see in terms of longevity, we're also seeing with reproductive longevity. So mTOR, what is mTOR? mTOR is a serine threonine kinase. It is a major metabolic regulator that is critically important to mRNA translation, cell growth, survival, and proliferation. The pathway is upregulated by various nutrients, growth factors, insulin, and IGF-1, and importantly is upregulated in 80% of human cancers. We also see that mTOR upregulation and activation is really critical to a number of age-related diseases. So we see that upregulation of mTOR can lead to a number of benign and malignant tumors, osteoporosis, metabolic syndrome, hypertension, neurodegeneration, atherosclerosis. So you can see this is a really ubiquitous pathway and really important in a number of conditions that lead to significant morbidity. And we also see that dysregulated nutrient sensing, and specifically dysregulated mTOR and mTOR activation, drives both somatic aging and ovarian aging. So not just aging of liver and all sorts of organ systems, but also aging of the ovary. And so mTOR inhibition then represents this really attractive target for improved health span, improved lifespan, and perhaps improved reproductive span. So ovarian aging, what does this encompass? There are two types of ovarian aging, two ways that the ovaries age. The first is due to iatrogenic ovarian aging, so due to medical conditions and treatments like chemotherapy, radiation, surgery. There are 100,000 reproductive age cancers diagnosed annually in the US. We know that the most common cancer diagnosed in reproductive age women, breast cancer, is treated with the most toxic chemotherapy agent to the ovary. So there are a lot of young women who are getting diagnosed every day with cancers that are requiring treatment that are going to dramatically impact their ovarian function. And then there's physiologic ovarian aging, and this is the ovarian aging that we all face. And there is this limited supply of primordial follicles. So the ovaries have this limited pool of follicles. We are born with about 1 million primordial follicles. By puberty, there are 300,000 primordial follicles, and by menopause, 1,000. And this loss of that limited ovarian reserve, that supply of primordial follicles that contains all of our egg cells, ultimately that loss culminates in menopause. And that loss is different for everyone. So women who are exposed to radiation and chemotherapy are going to have a much faster rate of decline at a much younger age. But for all women, the average age, for those who are not exposed to these kind of insults at much younger ages, the average age of menopause is about 51. And as the ovaries age, they are facing this age-related decline in both egg quantity and egg quality. And so when we think about quality, we're really thinking about what is the likelihood that an oocyte can be fertilized normally when it's exposed to sperm. And the blue line is the percent of maximum fertility, and the gray line is miscarriage rate by age. So in our 20s is really the highest likelihood that an egg is going to fertilize normally. And as the ovary ages, we see more chromosomal abnormalities happening, like trisomies and monosomies, that ultimately lead to miscarriage and infertility. And the crux of the problem in terms of fertility is that we are starting our families later. So the age of first birth in the United States continues to rise. This is 2016, where the average age of a woman's first birth was 26 years. This really depends and differs tremendously based on the region of the country. So we see in the hot pink areas, that's the youngest age of a mother at her first birth, and the deep green is the oldest age of a mother at first birth. And we see, not surprisingly, a lot of our deep green in urban centers: Chicago, New York, LA, San Francisco. And if you look at county level data, and you look specifically at Cook County or New York City and Manhattan, you see that the average age of first birth is incredibly high, and then that gets even higher when you factor in someone's education level. And so this unfortunately means that we are really shortening our window of reproduction tremendously. And more women than ever are having their first child between 35 to 39 years of age, or 40 to 44 years of age. And so this just means that if we are starting our families this much later, then the ability to achieve one's desired family size is going to be lower. And we are seeing a lot more unintended childlessness and a lot more reliance on donor eggs for conception. And it's because we live in this culture of competing interests. So this is looking at someone's age of first birth based on their educational level. So looking at high school or less at the bottom, and then a 2-year degree, a bachelor's degree, and then a master's degree or above, and then the median age of first birth. And so again, this is just hitting home the point that the longer we're spending educating ourselves, then the harder it is to then achieve our desired family size, because we are spending our reproductive years focused not on reproduction. And unfortunately, this is Pew data showing kind of how women feel about the question: a woman who wants to reach a top position in business is better off having children early on in her career or not having children at all. The answer to this question that women, the way they addressed this question was the majority believed that delaying or avoiding motherhood was the best way to achieve career success. So we're unfortunately setting ourselves up for failure when we think about the biology of the ovary. And in vitro fertilization, what I'm doing every day in my practice, taking care of patients trying to achieve their pregnancies, unfortunately, IVF cannot easily overcome age-related fertility decline. We see that on the left, the live birth rates by age for egg donation compared to someone's own eggs. The top line, the purple line, is donor eggs. So we see that there's really no difference in the likelihood of conception if someone's using eggs from an egg donor versus using one's own eggs. There is almost an impossibility to achieve pregnancy with one's own eggs by 45 or above. And then commensurate with that, we see increased rates of miscarriage with age because of the chromosome abnormalities we're seeing with declines in egg competence. And so when we think about fertility first, what options do we have to right now to preserve fertility? So thinking about this tremendous impact of age on fertility, there really are two approaches. One is we can freeze eggs, we can freeze embryos. And that would be a whole another talk to really dive into the differences between egg and embryo freezing. But the reality is, these options exist, but they're expensive, and certainly there's not access for all. And it really is limited to whatever we're able to freeze. If we're freezing 10 eggs, 15 eggs, what are the chances that those eggs are going to help someone really achieve their desired family size? There really are still, quite a few limitations in what we can do with fertility preservation. And really, we're only able to preserve fertility in this kind of reproductive age patient. The highlighted patient here is, let's assume she's 20 to 40. And there's this, whole kind of, there are limitations to kind of the technology that exists and the limitations to what we can do for older patients, certainly, and then for younger patients. In patients who are pre-pubertal, the only option right now to freeze ovarian is to preserve fertility is to freeze ovarian tissue. So we think about this with our young cancer patients who, are going to be exposed to chemotherapy, and certainly their ovaries are definitely going to age at a young age because of their exposures. So we can freeze ovarian tissue and potentially put that tissue back into them at an older age. In some cases, in adolescence, we freeze eggs, and in peripubertal, perimenarchal kids, we can, in some cases, freeze eggs, but there are some limitations to that as well. But I think the bottom line here is that when we are preserving fertility, we're really only preserving the small number of gametes, and it does nothing to think about ovarian function as a whole. And we also know very little about oocyte developmental competence at the extremes of reproductive age. We know at the extreme older ages, so 45, 50, kind of what we're looking at when we see high numbers of chromosome abnormalities in older ages, but in young patients, we know that there is a lot that we don't understand. And when we're freezing eggs and freezing ovarian tissue from these very young girls, to kind of mitigate that impact on ovarian aging, what is the quality of those eggs that we're freezing? A lot remains unknown. So we are currently looking at patients who are going through these treatments and looking at the cumula cells, which are the cells that surround the eggs, and pro-inflammatory cytokines in the follicular fluid, so the fluid that surrounds those eggs, in adolescents who are undergoing egg freezing, to really understand what's the reproductive potential of eggs from young girls and adolescents, to kind of open up this window into what we really don't know about the other extreme of reproductive age. And we really want to understand how the ovaries age, and we're hoping that this can help, because we know that from the moment a baby is born, her ovaries are aging, and in fact, her ovaries are aging in utero. So why is this happening at such a young age, faster than any other organ system? But when we move away from fertility for a second, we know obviously when we think about the ovary, it's hard not to link that with fertility, but the ovary is so much more than fertility. The ovary plays a critical role in cardiac function and cardiovascular health, mental health and cognitive health, bone health, and sexual health. And this comes down to estrogen. The ovary produces estrogen, and estrogen is critically important for the function of all of these different organ systems. And when we think about the ovary and its role in producing estrogen, what is important to think back to is the average age of menopause and female life expectancy. So we talked earlier about how female life expectancy is significantly greater than it was, 100 years ago. We're living 30 plus years longer, but the age of menopause hasn't changed. So the average age of menopause is 51, and this really hasn't changed over time. And so this means that women are spending potentially a third of their life in menopause, and menopause is associated with a number of morbidities: cognitive decline, depression, cardiovascular disease, diabetes, bone mass disorders like osteoporosis and fracture, sexual dysfunction. And as this gap widens and we live longer, it means we're living longer, but not necessarily healthier. And importantly, an earlier age of menopause is associated with a shorter life expectancy. So if we look at, and this is just one example of a paper where there are many more, if we look at women who go through primary ovarian insufficiency, so essentially menopause before the age of 40, which is what that definition of POI, or premature ovarian failure, is, that causes a decreased life expectancy by 1 to 2 years. And so the earlier the age of menopause, the slightly lower the life expectancy. And in 2017, the North American Menopause Society put out their updated position statement indicating that women with early menopause and POI have health risks that may include persistent vasomotor symptoms, bone loss, vulvovaginal atrophy, mood changes, increased risk of heart disease, dementia, stroke, Parkinson's disease, ophthalmic disorders, and overall mortality. And so this is really important because this is just hammering home the point that estrogen is really important. The ovary has really important functions for overall health and mortality. And what I think is striking to think about is that when we look at every other organ system, we can kind of predict, we know when other organ systems age, kind of progressively in the 60s, 70s, 80s, but the ovary is the first organ to age by decades. It's the organ system where there is just truly no function after early 50s. And that is so different than other organ systems. And so this, begs the point that we really need to be thinking about how do we protect ovarian function in the face of both iatrogenic and physiologic ovarian aging. So if we think back again to kind of the physiology of the ovary, we've got all of these primordial follicles. So these are the follicles that contain premature egg cells. These are egg cells that are dormant and arrested in prophase of meiosis 1. And we've got this, pool of 1 million of them, and then 300,000 at puberty. Every month we ovulate one antral follicles. We've got these primordial follicles that grow to be primary follicles, secondary follicles, and then ultimately the pre-ovulatory antral follicles. Every month we ovulate one of these antral follicles and lose 1,000 more follicles. So there's this tremendous drain in the follicle pool with time. And the Mtor pathway, so now circling back to that important ubiquitous Mtor pathway, is really critical to primordial follicle activation. So in the same way that it's important for translation and proliferation in a number of other organ systems, it's really critical to this activation of primordial follicles to primary follicles. And so this has a number of really exciting clinical implications. If we could potentially prevent that proliferation from primordial follicle to primary follicle, we could preserve fertility and preserve that primordial follicle pool and potentially delay or mitigate ovarian aging. And so again, thinking back to mTOR inhibitors. So inhibitors of this pathway have been shown, like rapamycin, there are a number of other agents that have been shown to prolong lifespan and health span in a number of species. So this is, just one such representation of this, where if you look at mice that are given rapamycin, they live significantly longer. And these drugs are used widely for benign and malignant conditions. So mTORC1 inhibitors, the example or the clinical name is everolimus, the drug company is Afinitor. Or Novartis, sorry, Afinitor. It's also called RAD001, which is how I'm going to be referring to it here. It is used in ER-positive, HER2-negative breast cancer, advanced renal cell carcinoma, astrocytomas, tuberous sclerosis, and these are FDA-approved indications for these drugs. There are a number of other indications that are, preclinical and a lot of really exciting work being done, but there are, these indications for which these drugs are FDA approved. And then there are the dual mTORC1 and 2 inhibitors, which I will be referring to as INC128, that are used preclinically in breast cancer, pancreatic, neuroblastoma, a number of cancers. Because again, remember that these drugs or this pathway is upregulated in 80% of human cancers. So it's no surprise that these are really attractive drugs in oncology. And so the kind of beginning of this was asking the question, well, if mTOR inhibitors can be used in cancer treatment already, and we know that mTOR is involved in activation from primordial follicle to primary, can we use mTOR inhibitors to protect the ovaries during chemotherapy? And so this is work that I did starting in my fellowship and then continuing on post-fellowship when I joined the faculty at NYU. And we found that mTORC 1 and 2 inhibition, when we administered these drugs alongside gonatotoxic agents, cyclophosphamide in particular, so the most toxic of the alkylating agents, we found that the cyclophosphamide alone led to a significantly lower primordial follicle pool in mice, and that co-treatment with RAD, which was the mTORC1 inhibitor, and INC, which is the dual mTORC1 and 2 inhibitor, co-treatment led to a significantly greater primordial follicle pool. And then we ultimately repeated this, looking not just at the not just the histology of the ovary, but looking at the behavior of the mice and the breeding behavior, and found that there was a significant preservation of fertility in the co-treated mice compared to cyclophosphamide alone. So ultimately, the question was, could these drugs preserve fertility? And the answer in that initial data was yes. And then we looked at, could these drugs then could potentially be used to prolong reproductive lifespan? And we then repeated this work using these drugs, RAD and INC. We mated the mice and consecutively bred them over the course of 11 months, and found that the mice that were treated with RAD and with INC had significantly more litters during the breeding period, and particularly those that were treated with the dual mTORC1 and 2 inhibitors. So essentially, these mice were mating more frequently and having overall significantly more litters compared to untreated mice, which was an exciting phenotype, particularly given that these mice were breeding for longer into their reproductive senescence than the controls. And so we can see here that the treated mice produced litters at advanced reproductive ages compared to control mice. And so in this lower right-hand graph, you see the blue is control. So these mice stopped breeding at an earlier age. The percentage of mice that were pregnant with each consecutive month of breeding was lower compared to the mice that were treated with mTOR inhibitors. But this begs the question, so mTOR is really ubiquitous in reproduction. We've talked about this, and ubiquitous kind of across all organ systems. And so we really need to be thoughtful about how we're considering using these drugs. So the mTOR pathway is really critical to primordial follicle activation and oocyte meiotic maturation, has an incredibly important role in the endometrium, somatic cells, post-fertilization events. And so when we think about this ubiquitous role, it suggests two things: that it warrants careful investigation regarding transgenerational risks. So if we're giving these drugs and it's so critically important to reproduction, could alteration of this pathway lead to any impact on the offspring? And then it also suggests, wow, if there's this ubiquitous role in reproduction, this gives us some exciting opportunities to better understand various ovarian aging states. So in my lab right now, we're looking at the impact of this pathway on ovarian aging states like endometriosis, iatrogenic ovarian aging, the role of BRCA mutations and diminished ovarian reserve, and how is mTOR altered in these states, and are there opportunities for intervention? So when we think about how these drugs could potentially be used clinically, there's kind of this small part of the pyramid where thinking about mTOR inhibitors as fertoprotectants, so protecting during chemotherapy. There's thinking about, the people who are currently using these drugs in clinical use. So we know these drugs are FDA approved. What would be the impact? All of these people who are using these drugs, and the impact on their offspring from using these drugs. And then could we consider using mTOR inhibitors to prolong lifespan or health span? The question remains, what is the safety of these drugs in subsequent generations? And that was what we wanted to find out. So we used these drugs and mated our treated mice, looked at the health of their offspring, and then looked at the fertility of not just the first generation, but the second generation after treatment. And just to very quickly summarize, where there is much more data than is being presented here, but just to put it kind of into a nice little package, we saw that in the F1 generation, so that's the generation of offspring where the mothers were treated with mTOR inhibitors and then they had pups. We saw that there were significantly more pups in the INC-treated mice, so this was consistent with what we previously saw. So again, there's something about these drugs that's leading to higher litter sizes in these mice. And the weight of the F1 pups increased appropriately with age. These were healthy offspring with no gross abnormalities, appropriate weight gain. And this was looking at both the female and the male pups in both the first and the second litters. And then we looked at the second generation, so the F2 generation, and found that there was no difference in the percent survival or pups per litter in that F2 generation. So that generation of mice whose mothers were treated, that generation was also fertile and had a normal generation of offspring. And we, when we think about, all these kind of findings that the mice treated with mTOR inhibitors from that initial study had twice as many litters and pups compared to controls, and that we see these reassuring animal data in terms of offspring, this brings us one step closer to potentially identifying a druggable target to preserve ovarian health and potentially promote health span and maybe lifespan when we think about the treatment of, the role of these drugs in longevity. And there's also, quite a bit of interest in the lay media when we think about these drugs. So, David Sinclair's book, Lifespan, I highly recommend it if anyone's looking for a compelling science read. He really goes into the data about why these nutrient sensing pathways are compelling targets for longevity. And he gave my work a little shout out in there, which was exciting from this David Sinclair fan. But there's some really compelling data out there looking at the role of mTOR inhibitors. And Malcolm Gladwell commented on it as well in one of his podcasts. It was his Revisionist History podcast. And, expressed interest also in this role of manipulating this primordial follicle pool and preserving these follicles to potentially improve ovarian health. So there's a lot of discussion of this, and I think that it's truly an exciting time to be in this area. Now, one area that I'm going to touch briefly on behalf of Dr. Duncan, she wishes she could be here, but her work focuses on not just the egg cells, but the environment that the eggs are in. Because if we're really thinking about protecting ovarian function, it means protecting not just the eggs, but truly the microenvironment. And so she has this nice analogy that she talks about when we think about kind of the eggs themselves and then the nest in which these eggs are in. And so the environment in which the egg develops changes with age. And we look at this is a 6 to 8 week old mouse ovary. And all these purple spaces, these are all antral follicles and follicles at different stages. And the brown staining is the ovarian stroma and all the tissue that surrounds those eggs. And that's a nice, healthy nest for all these young, healthy eggs. And then on the right, we see this pretty shoddy looking nest with some broken eggs. And really that's what the ovary itself looks like too at that older age, that we don't see very many healthy eggs or follicles, and we're seeing a lot of stroma that is looking unhealthy. And so what her work has shown is that the mouse ovary becomes fibrotic, stiff, and inflammatory with advanced reproductive age. So we see here a 5-month-old mouse, and then an 18-month-old mouse, and then a 22-month-old mouse ovary. And these are increasingly fibrotic ovaries. And when they actually apply force to different points of the ovary's surface, they see that there's that the ovary becomes stiffer with age. And this is where having this clinical and lab collaboration is really a beautiful thing, because we talk about these things and we compare data, compare notes, and clinically, when I'm doing an egg retrieval on a woman who's of an advanced reproductive age, often it does feel stiffer. It feels a little bit harder to get that needle through the ovary, and it's what she's seeing in the mouse and what she's seeing in her lab. And so there's this really nice interplay that we see when we look at the clinical and the fundamental science as part of this continuum. And then she's also seeing that there's higher levels of interleukin-6, an inflammatory cytokine, in the older ovaries. And this is now looking at human ovaries. They're also seeing this in human ovaries. So you're looking at a young 17-year-old ovary, a 45-year-old ovary, and a 58-year-old ovary. And we're seeing these kind of inflammatory biomarkers of female reproductive aging. And she, if she was here, she would also talk about the importance of senescence and this big network that is now being kind of worked out through multiple institutions. She is going to be contributing ovarian tissue to this CENNet, the Cellular Senescence Network, through the Buck Institute, where she has an appointment. And so this is an almost $13 million grant from the NIH to look at the role of senescence in the ovary. So there really is a lot of exciting work happening clinically and across both of our labs and across a lot of the labs within our institution. And we have really a unique role here and a unique organization in that there are a lot of people at Northwestern who are very engaged and interested in reproductive health and reproductive aging. And I think we represent an institution that is well positioned to answer a lot of these questions that are right on the frontier of reproductive longevity. But taking it back to why we're asking these questions, this is a question that I am asked almost every day in clinic. No one told me this could happen. How am I 42 and unable to use my own eggs to get pregnant? Like, I don't understand. I don't feel old. How is it that we have nothing that can overcome this? And I think that we're really missing some critical opportunities for patient education and reproductive aging. I think every woman I speak to says that she, really didn't understand how rapidly the ovaries age and felt like she spent her whole life hearing about ways to avoid getting pregnant. And really there was so little attention made to think about ensuring that her reproductive goals are met. And so this is a paper I wrote last year, a couple of years ago now, with one of our OBGYN residents, and then two additional co-authors who are at NYU. And we were looking essentially at what are the guidelines telling physicians, like how are we teaching our own to teach our patients in terms, what should we be telling people at age-related fertility decline, and what do the guidelines tell us? Because we know in medicine we have to be adherent to guidelines, ACOG, Royal College, AAFP, all the guidelines that kind of dictate what we need to be talking to our patients about. And the guidelines are pretty abysmal when it comes to how should we talk to our patients about female age-related fertility decline. So I think there's a really great opportunity here to think about better ways to be bringing this into our routine counseling. And, the problem is when we're not talking to our patients about it, they're getting information from elsewhere. And so we looked at, this is with a prior medical student, we looked at, magazines, just like the magazines you pick up on the shelf, like what are they saying about age-related fertility decline? And as we all know, we didn't need a study to do this, but it's always nice to have data, kind of quantified data to look at these things. As we all know, like there are so many misrepresentations of fertility in just celebrity-driven media. So you'll see these, magazine covers of like miracle baby at the age of 50. And we know, those in the field know that that's either someone who froze their eggs at a younger age or froze an embryo at a younger age, or they use donor eggs. But none of the magazines, of course, because celebrities are, they are welcome to their own privacy just as we all are. But, if you're looking at that, you may assume, well, if she got pregnant at 50, I can too. And the reality is that's not how ovarian biology works. And so I think we need to do a better job of educating our own. And so this is last year, the USPSTF put out recommendations for well woman care. And these are the general prevention services. So general health, infectious disease, cancer. It goes into every kind of screening that you can imagine that OBGYNs should be talking to their patients about. Lipid screening, obesity screening, osteoporosis, statins, tobacco, urinary incontinence, anxiety, all the things that, yes, are so important, but nowhere on here is fertility and age-related fertility decline. And it feels like such a missed opportunity. And so my fabulous fellow, Dr. Bakkenson, and I wrote this commentary, Women's Preventive Services Initiative, Fertility Counseling Overlooked, highlighting that, if we are going to be comprehensive women's health providers, we need to be thinking about how women can achieve their goals and specific to their fertility. So it really is an exciting time to be part of the discussion. There's so much happening when we think about fertility preservation and fertility counseling and longevity. And so if we think though about kind of taking it back a step to like, how do we achieve a healthier life? We really need to be thinking about how do we achieve a healthier reproductive lifespan. And so with that, I would love to just thank some of my incredible collaborators and colleagues and trainees. So within my laboratory, Dr. Bakkenson, who's one of our fellows, Lauren Butler, who graduated from the master's program last year, Jillian Rubenstein, Ria Marate, Manuel Torres Velez, just absolutely phenomenal trainees who are making a tremendous mark. My collaborators within the Duncan Lab, particularly Francesca Duncan, who is just a brilliant ovarian biologist, the Northwestern Center for Reproductive Science and Masters in Reproductive Science and Medicine, my colleagues at NYU, and then particularly my funding through Friends of Prentice, who have they have been just endlessly grateful with the funding they are providing me. With that, I would be thrilled to take any questions that you may have, and thank you so much for your attention and for being here.
Thank you, Dr. Goldman. That was a wonderful presentation. I'll start first with this question that we had received earlier. What do you consider to be the upper age limit for IVF, and why?
So it really comes down to thinking about, and I can stop sharing so we can all just kind of chat here. So it comes down to the likelihood of achieving that getting that healthy egg and a normal embryo. And when we look at the rate of chromosome abnormalities in women who are, 42, 43 and above, we see so many chromosome abnormalities that it becomes really inefficient to go through IVF. So at our center, by someone's 45th birthday is the upper age limit. And that differs a little bit. And there's a lot that goes into that decision making in terms of, patient autonomy and, patients wanting to, certainly if someone feels like they, want to keep trying, we certainly, you don't want to be a gatekeeper, but there's also this, consideration of futility and just wanting to be responsible, and not giving someone false hope. So 45 is the upper limit, but I would really counsel someone to be thinking about this far, far earlier, if possible.
And could you please comment on possible causes and approaches for a 33-year-old with recurrent miscarriages who's had normal genetic testing and a fertility workup for both her and her spouse that were normal?
So hard. To whoever asked that question, I'm sorry that you're going through this. It's so hard and heartbreaking. When we think about recurrent pregnancy loss, there's really a few, we know that the most common reason for miscarriage is chromosome abnormalities. And so we always want to know, if possible, what were the chromosomes of the miscarriages that happened. And so if there is that data, if we know they were chromosomally abnormal, we can say, well, that's why that pregnancy was lost. If they were chromosomally healthy pregnancies, then we start thinking about things like a uterine septum, so a structural abnormality in the uterus that can increase the risk of miscarriage. We think about things like adenomyosis, which is kind of a subset of endometriosis. We think about hematologic or immunologic issues, antiphospholipid antibody syndrome. So there's a whole workup that we do. And in some of those cases, if we don't find a reason, then, we can be reassured that still the most likely next pregnancy is going to be a healthy pregnancy. That's what the data says. But, that's really when you should start kind of consulting with, my group and my partners or just a reproductive endocrinologist to support you in that.
Helpful. How would you envision mTOR inhibitor treatment being used clinically?
So, I think what's exciting about, finding a potentially druggable target is if we could find a way to administer these drugs at an age where, there could be benefit in terms of, giving them in someone's mid-30s. If we know there's going to be prolongation of, or delayed childbearing, potentially we could kind of get a few more years of reproductive health. I think the goal would be, could we find kind of the lowest amount of drug necessary to achieve some some ideal kind of couple additional years of ovarian function. And the goal here is never, when we think about these things, it's never to be, allowing women to conceive into their 70s. I think that like there's always this fear that we're trying to kind of push the envelope to places that everyone's ethically very uncomfortable with. And that's not the goal. I think when I think about my goal is I take care of women who are in their early 40s, who are in this window where they are just not successful with their own eggs. IVF is not able to overcome their, age-related fertility decline. If we could have gotten kind of a year or two more of ovarian health, maybe that would have been different for them. So the goal really would be, finding an age where we could kind of administer drugs for a short amount of time. And in the mouse models that I've used, we've given these drugs at 8 weeks of age. So it's a kind of an early reproductive age mouse. And we've only given the drugs for 4 weeks and saw that phenotype of prolonged longevity. So this could be, there might be something there where if we were to do this in humans, we find this short kind of amount of time that we could administer these drugs to get this phenotype.
When should a woman think about freezing her eggs?
So, it's, I think the idea of fertility preservation, I mean, we are at such an exciting point right now where we finally have something, where, even 15 years ago, this of course was not a routine part of the conversation. And we now have data that, we know this works. We have a lot of women coming through and doing this, and we're still trying to find that right age. A lot of that comes down to how someone envisions the next 5, 10, 15 years of their life. And I talk to a lot of our trainees, a lot of our residents, and I think especially when we think about medical trainees, just knowing who our audience is today, this is a group of women who know they're going to be spending the next 4 to 12 years in intensive training. And so this is a really, I think, important group to be talking to about this. And Northwestern is actually one of the only institutions that I'm aware of that covers this for house staff. So our residents and fellows have coverage for egg freezing and embryo freezing. And it doesn't mean that they should all do it. It doesn't mean it's right for everybody. But certainly if someone knows they're going to be delaying childbearing for the next at least 5 years, they know they want a number of children. They know that they want to make sure they have genetically related children. It's an important conversation to have. So I think to answer the question, a lot of the cost effectiveness data looks at, 38 and below is more cost effective, 36 and below, depending on what study you're looking at. But honestly, the youngest age at which you think you're going to want to do it, you should do it.
Circling back to the mTOR inhibitors, could these drugs be used to keep ovaries functioning to reduce the impact of estrogen-related health issues?
That's exactly what my pie in the sky goal would be, is that if we could think about not just fertility, so not just that 42-year-old who could have had a couple extra years of fertility, but will that extra, if someone has ovarian health and and endogenous estrogen for another 2 years because their ovaries are still producing estrogen, could that, what would that impact be? I suspect, based on everything we know about estrogen and everything we know about hypoestrogenemia and mortality, could, that extra couple of years of ovarian lifespan could prolong lifespan. So, that's my kind of pie in the sky. Yeah. And that's where, when we think about ovarian tissue freezing, that's, some of the data looking at ovarian tissue freezing is if you take out an ovary and then take little pieces of that ovary and put it back at an older age, you're giving someone back their own estrogen, their own kind of, ovarian tissue. That requires multiple surgeries though. And it's still kind of in its relative infancy in terms of looking at, how long these grafts can function when we put the ovary back. But this is really the frontier. This is what's next with women's health, and is really trying to understand how to prolong the life of the ovary.
And let's see, one more. What would you tell a young woman about potential ways to extend her reproductive health?
I think that so this is where we have, there's still a lot we don't know. We know that a lot of this is genetic. So we know that a mother's age of menopause is, often going to predict your age of menopause. And so any young woman who knows that her mom went through menopause at a young age, so I would tell someone if they knew their mom went through menopause earlier than 50 and especially earlier than 40, I think that's worth diving into a little bit more and figuring out, is there any other history? Talk to your OBGYN about it, talk to your reproductive endocrinologist about it. So there's the genetic kind of factors. And then like the biggest is, the only environmental exposure that we know of that can impact fertility is smoking. So this is often when I'm talking to my, fertility patients who smoke, I think it's one of the most compelling reasons to stop smoking when you think about women who, like, I think when they suddenly realize like this smoking could impact their ability to have children, like that speaks to them. So definitely don't smoke because that's the only thing that we know of. And then I think whenever there is, risk of an environmental exposure, be an advocate for your fertility. I've seen far too many young women who went through chemo and didn't know about freezing their eggs or preserving fertility beforehand and feel just totally devastated and blindsided by the loss of their fertility. So I think being an advocate for thinking through, like, is this going to affect my fertility? How? And let's have a conversation about it.
Well, I think that's it for our questions. So I want to thank you again, Dr. Goldman, and thanks everyone for joining us. It was so great to have you here.
Thank you so much. So great to be here, and thank you for the opportunity.
Yeah, have a great afternoon, everyone.
Thank you.